everything that we've been talking about lately is prevention. And that's the key to this talk tonight. As much as you hear on television about diabetes and our government wanting to change diets and all of that kind of stuff, the fact of the matter is that even before you get to the point where we're 500 pounds and we're 55 years old, what I'm going to show you is that this is actually a preventable disease. I know I've put a lot of you on a lot of different medications. I've made a lot of recommendations. But I'm going to prove to you that there's a reason. It really does work. Now, some of you have heard a little bit of this before, but I'd like to start with a little philosophy, if you will. And if anybody finds fault with it, please, we'll argue later. But I think that most of us would agree that on this earth, there are gazillions of different species. Man is one of them, and we are, of course, we're the thinkers. We're intellectual. But outside of that, our genetic makeup as a species is very much like every other species. We're here to procreate, to make our genes last forever, and to have our genes go through our children and their children and their children. That's kind of the goal, right? Genetic maintenance. Well, we're also genetically inclined to die as much as we are to live. And there's a reason for that. The reason is that once we're done making all these babies, we eat the food of our young. They can't get older, they can't develop, there's not enough for them, and the species would die off. In fact, many species, after they give birth, they die, right? The queen bee, that's the perfect example. So when you look at how we're made, it's all about reproduction. Everything is there to make our reproduction systems work beautifully, and they do. We have good, strong bones, right, as women, so that we can carry children, and it wouldn't surprise you that estrogen helps in maintaining those bones. Similarly, our thought processes, everything that we do, our cardiac, the idea that estrogen causes heart attacks is probably not the case. We just don't know what that relationship is. But indeed, prior to menopause, women don't have heart attacks because they need really strong circulatory systems in order to maintain two beings, themselves and a baby. The same is true of men. Everything that we do and we are, our beautiful skin, our lovely hair, whatever it is, it's all about attracting a species, a mate rather, and procreating. Then of course we go through menopause, or menopause, whatever, and as we get older, things start to break down. So we're genetically inclined to deteriorate after menopause. But we've decided as a society and as a culture that that's not good. We don't want to do that. We want to extend our prime. But in order to do that, we have to first understand our genetics, and we have to secondly understand these disease processes so that we can do that legitimately. Does that make sense? So what we're going to do is we're going to try to take a system that is designed to die off and make it work for another 35 years? I mean, that's what we're talking about here, right? Menopause, depending upon the person, occurs at 50, 55, and we're talking about living until 90, 95. So when we talk about osteoporosis, we're not waiting to get osteoporosis, we're going to prevent it because we're going to get to be 95, our bones are going to deteriorate. It just is going to happen. Diabetes is a disease of the elderly in large part. It's becoming a disease of the younger, because the younger indeed are eating too much. That's a story in a minute. But indeed, if I check the sugars, the 2-hour glucose tolerance test, in people over the age of 70 or 80, everybody has diabetes. Why? Because the cells are wearing down. They're just not as functional as they used to be. So it's not that everybody is diseased. I'm not giving you, a 4-letter word to wear on your forehead here. What I'm saying is that we're going to have to do something in order to keep you alive and well to the age of 95, because genetically you may be predisposed to get diabetes or for those beta cells to fail. Does that make sense? So before you get all tangled up in the word diabetes, because as soon as I mention that to many of you, oy vey, you just want to go home and get a gun. But it's absolutely not necessary. if this were 200 years ago, just 200 years, not 10,000, but just 200 years, the average age of death was in the mid-50s, right? People died of infection. Then we got sanitation and all that other good stuff, and here we are today, and our expectation has changed. And so within the context of that expectation and extending your prime, we got to do something about it. The other analogy that I like to use is the analogy of a car. If you lease a car and you're only going to have it for 2 or 3 years, you treat it one way. If you own it and you want to own it for 50, you treat it another way. You own your body. You own it from day one. And so all the things that we do to it matter. They count. Now, you can change it after a while. I mean, even the old car that's, 30, 40, 50 years old, you can get it all pumped up and get it running again. It takes a lot of work, though. It takes a couple of new parts, hence the new hips, if you will. And now, of course, we have stem cells to rejuvenate some of our organ systems. In fact, we now have some evidence that stem cells actually work and are part of the whole rejuvenation of the pancreas and preventing diabetes. We're going to talk about that in a moment too. So this is about extending your prime. This is about investing in your life. This is why I'm doing the Z Life. Because the Z Life is about all those things that you can do to invest in yourself. It is not typical medicine. And what you're going to see as we go through these slides is kind of an embarrassing situation for medical care in this country. The truth. How many of you have ever had an A1C, and that's your average glycosylated hemoglobin, of over 8? And you don't belong to choice care. That's the average glycosylated hemoglobin when diabetes is diagnosed in this country. So, type 2 diabetes is an epidemic in this country. 20.8 million Americans, or 7% of the population, think they have diabetes. But remember, that's in the context of what I told you. The majority of people are having their diabetes diagnosed way beyond its time. Way beyond. In fact, when sometimes they've already had a heart attack, and we're going to show that in some of the slides as well. That is absolutely irresponsible. But that's why you're here. I'm embarrassed for the American medical healthcare system, because that is an absolute embarrassment. It is the 5th leading cause of death. It is the leading cause of blindness, the primary cause of end-stage renal disease, and 60% of non-traumatic amputations are caused by diabetics. That's a lot of stuff, all of which doesn't need to happen. And for those of you, again, who I'll remind are on those medications that you have to think twice or 3 times about before you take them, that's why you take them. Because you're never going to be blind, and you're not going to have an amputation, and your kidneys are going to stay absolutely healthy until you're 100. That's why you take those medications, because without them, this disease is a progressive disease, and it leads to horrific complications. That's the problem with diabetes, and we haven't even begun to talk about the cardiovascular complaints. Next slide. This is the current natural history. GDM is gestational diabetes. How many of you know someone who was diabetic while they were pregnant? Common, right? And many times somebody says, oh, they just had diabetes during pregnancy. That person has diabetes. Hear me again. That person has diabetes, and they actually already have diabetes. The fact that pregnancy made them a diabetic tells you that they already have beta cell dysfunction. They should already be treated, and this is the course of their history. And as you can see, in the United States, that diagnosis is being made almost 10 years after the fact. 10 years when they've had vascular complications, the potential for blindness, the potential for heart attacks, the potentials for strokes. That's an atrocity. That can be changed. Now that you know it, tell your friends. Anybody that has a daughter who's pregnant who's got diabetes while they're pregnant, they need to see an endocrinologist. They need to start their treatment immediately. They can prevent the complications of diabetes if they start treatment immediately. Next slide, please. This is another slide talking about the natural history of diabetes. And this is the crux. If there's any one slide that you remember, this is what I want you to see. Look at the point 0. The point 0 is theoretically when the diagnosis of diabetes would be made. And that's because, as you can see on the top, that blue line, we're seeing that post-meal glucose. You know that yucky orange stuff that I make you drink? That's a 75 gram amount of glucose. It is sugar. It tastes so sweet because it's 75 grams of sugar. And what we do is we then test your sugar, as you know, after that. It is theoretically that of replacing a meal, the glucose that you would have during a meal. And as you can see, the glucose has gone up to the point where in this country we've been diagnosing diabetes. In this country we've been calling a 2-hour postprandial glucose of over 200 as diabetes. Some say 180. In this office, and the newest recommendations are anyone with a sugar over 125 at 1 hour post yucky stuff, that's diabetes or pre-diabetes. That's the time when you know you have a problem. 125, 1 hour after you take the 75 grams of sugar. Okay? But here's what I want you to see. This third line down, it's called insulin resistance. It's labeled insulin resistance. That starts, as you can see, 15 years prior to that diagnosis. 15 years. This is where we're making the diagnosis. We're starting to see insulin resistance. I'm going to show you a slide later about insulin resistance. In a nutshell, what it means is that the cell doesn't respond as quickly as with the same sensitivity to insulin. So you see the insulin, theoretically it should be able to take up the sugar into the cell, get it into the mitochondria, get it into the fuel system, but it's a little bit slow. It's kind of like the gas pedal that when you put it down to the ground, the car just still isn't moving too fast, and you've got to take it to the dealership and get it fixed. Insulin resistance is that gas pedal that's just not as responsive. Now, the other important line that you need to see is the progressive beta cell dysfunction. God bless you. Beta cells are the cells in the pancreas, and I'm going to show you a picture and explain them in just a moment. They are the cells that make insulin. This is the genetic defect. If you are genetically inclined to get beta cell dysfunction, you will get diabetes whether you're skinny or fat. I'll repeat. If you have beta cell dysfunction, you're going to get diabetes, skinny or fat, but it'll be later on in your life if you're skinny. It'll be earlier when you're fat. Hence, the difficulties that we have with our children these days. They're heavier. The other thing, and I know that this may sound a little bit politically incorrect, but the genetics of the American person is not the same genetics as it used to be. Back in 1700s, we were settled from Europe, right? We had European genetics. My husband says to me that he was raised in a community in Minnesota and then in Washington, and they were all Lutheran Norwegians, and they all married each other. So the genetics was relatively pure. It was Norwegian genetics, and guess what? They don't get diabetes. They're all thin. They got small little butts. Oh, I'm so jealous. Tall, what can I say? But that's not my genetics. I come from Eastern Europe, and we have a huge Hispanic community in this country now. It's just a fact. And we're having intercourse with Hispanics. Somewhere down the line, we have integrated our genetics. We are absolutely, the soup, whatever you want to call it. We've integrated our cultures. We talk about that. We're proud of that. But with that comes the genetics that integrates and the diabetes that has entered our culture. So we're just not all purely living in a community where we literally marry each other anymore. This is not a ghetto. We're very proud of that, but with that comes the risk of whatever genetics came with the person that you married. And who knows these days, how, if you go back too many generations, we come from all over the place. So we have the genetics. And at some point, if you're interested after this, we can talk about the genetic herds of people and how they actually traveled through Europe, and the idea of man as a herder, someone who went out and got animals and killed them, versus a man who became a farmer. And their genetics were actually quite different, because if you were a farmer, you had to be able to eat grains and wheat, and so you didn't have as much diabetes in that community. Why? Because they genetically ferreted that out. So you see how this mix of genetics then actually increases the potential for beta cell dysfunction. Everybody in the world at some point in their life can become a little bit insulin insensitive. Insulin resistance can happen. We all have too much to eat. We all sometimes gain a little weight. That is the problem surmounted on the genetics of beta cell dysfunction. It is the beta cell dysfunction that we need to center our mind on. It's that cell that's not doing what it needs to do. It's making insulin, and the alpha cell right next to it is making glucagon, and we believe that that cell as well, those genetically predisposed problems will eventually lead to diabetes, thin or fat, which is not an excuse to have any extra cheese tonight. Okay, next slide, please. Now, what I've done is I've superimposed on that slide a very important curve, and that's the red line, cardiovascular events. Can you see that even over 10 years prior to the diagnosis being made, you were already having heart attacks? The effects of diabetes have already started prior to the diagnosis. What a shame, because that could have been prevented. I'm going to show you how. But that's why I'm so insistent, and I'm a bugaboo about this stuff, because I truly believe that if we're going to live to be 95 and live well, we have to treat ourselves like a brand new car. You know, looking like a brand new car, feeling like a brand new car, and you gotta take your medicines like a brand new car. Next slide. This is the pathogenesis, the concept, and mind you, it's a concept. Every day, you know, one day broccoli is good, the next day broccoli isn't so good, but this is really where we think diabetes comes from. We talked a bit about the genetics. We talked about obesity, aging, and lifestyle. If your beta cells are healthy, they'll compensate and you'll remain what they call euglycemic. That means normal sugars. Your sugars won't pop if your beta cells are functioning. However, if they are susceptible, the beta cell dysfunction ensues. You will progress to a pre-diabetes state, and then obviously over time start to develop full onset diabetes and all of the complications that ensues. And there's not one person in this room who I will tolerate having a heart attack or a stroke. It is absolutely an intolerable event. It's just not going to happen because it's a bad thing. Right, Ellis? Next slide. Weight loss can help. So I didn't mean to poo-poo weight loss because Lord knows we're all on a diet from day one, but it does really matter. It does improve your survival. And for every kilogram, a kilogram, by the way, is 2.2 pounds. And it's associated with 3 to 4 months of improved survival in those with diabetes. So imagine if you lost 22 pounds, that'd be 30 months or 2 years of survival. That's not bad, right? So 20 pounds is, we could all lose a little weight. And you can see that at the same time, a 5 kilogram or a 10 pound weight gain increases the cardiovascular risk by as much as 30%. So hopefully that will keep us from eating the second piece of cheesecake. Next. There are a variety of proposed preventions and early treatment. This is just kind of schematic. But certainly diet and exercise help with annual follow-up, although I think it should be more often than that. If your glycemia is stable, theoretically you can continue your diet and exercise, but we're a lot stricter around here. Because indeed, if you have any high risk, I really believe that you need to have constant treatment and constant vigilance. But in general, the pre-diabetic needs to be treated like the diabetic. We have to work just as hard to continue the prevention as we do to maintain the glycemia if indeed you have the disease. Don't fret though, I'm going to show you where those with diabetes can actually have improved function. So I don't want you to get too depressed in this. We really can change the course of the disease even if we are beyond the diagnosis. Next slide, please. This goes to show you that metformin is glucophage. Some of you take glucophage, some of you take metformin, depending on the brand, whether you take the brand or you take the drug itself. But as you can see, there was a very, very, very important risk reduction in those people who took metformin. There was also a risk reduction in people who did lifestyle changes. So lifestyle changes do count. And for those of you who really want to maintain risk reduction, I would think medication plus lifestyle changes would give you remarkable risk reduction, and you feel better. Next. This is actually, there's some trials that we're going to talk about. We're going to talk about the DREAM trial. We're going to talk about the ACCORD trial. We're going to talk about a whole bunch of trials that were done with various medications. Metformin is, as I said, that's glucophage. The triglycerin and the rosiglitazone, those are drugs like Actos. We don't use much Avandia in this office, and rosiglitazone, the drug Resulin is off the market now. But you can see the risk reduction. With the pioglitazone, it was the trial was too small. But you can see there's very significant risk reduction using the triglycerides, the triglyzones. And in this office, that's your Actos. For those of you who have been spending that money, this is why. Remarkable risk reduction. And as you'll see, it stabilizes beta cells. It stabilizes beta cells so that the progression of the disease stops. As you can see, metformin does have some risk reduction, but it is certainly not in keeping with the rosiglitazone or the rosiglitazone or the triglycerides. Acarbose is a drug we don't use too much because it causes horrible diarrhea and gas. But what it does is when you take acarbose, it interferes with the enzymes that are necessary to dissolve carbohydrates in your stomach. So you can't absorb carbohydrates. So it's kind of like if you were milk intolerant. You know, diarrhea, gas, not so good. If we have to use it, we can, but I try to stay away from it because the discomfort is just, but you can see that with that also comes some risk reduction. So there's lots of things that you could do, and obviously you could do the same thing if you didn't need as many carbohydrates. Does everybody know what a carbohydrate is? Let me explain again, because that, you know, when you're in school, when I was in school, they taught us the food pyramid, you know, like a milk group and a meat group, as if your stomach or your brain understood milk and meat. Crazy. So there are three major food groups: carbohydrate, fats, and proteins. Those are the three major food groups. And of course, those are the nutrition, that's how we get our nutrition. In all, the proteins are broken down into carbohydrate. Carbohydrate is anything that's made up of a glucose compound. Multiple glucose compounds or multiple sugar compounds all strung together make something called glycogen, and that's how it's stored in our body. Fiber is carbohydrate, but it's a long carbohydrate. And sometimes we don't have the enzymes to break up that carbohydrate completely. So some of it actually doesn't get absorbed, so it doesn't really have calories. Some fiber, some of the glucose in it does get absorbed. Fruit is carbohydrate. Fruit is sugar. So while I love Weight Watchers and I think it works beautifully, diabetics are just not made to have lots of fruit. And you can prove that to yourself. I invite you to come in here and have a great big bowl of fruit, and I'll check your glucose in an hour, and it'll be just as high as if I gave you 75 grams of that yucky stuff. Because it doesn't have a lot of fiber in it, depending upon the specific fruit. And you know by the sweetness what fruits got more stuff in it. So grapes, very sweet, lots and lots of sugar. Oranges, apples, bananas, sorry. But you're better off with strawberries, watermelon, and cantaloupe and honeydew. They tend to have a little less sugar. So if that's the kind of stuff you like to eat, you should eat the berries over the others that are just strongly. And that is the biggest mistake that diabetics make. They think that for dessert they won't eat the piece of cheesecake, but they have a huge bowl of fruit. And their sugars go up to 200, 300, 400. It can really be astronomical. So fruit is glucose. Proteins are your meats, your fishes, all that kind of stuff. The liver actually transposes the protein to a glucose, and you can use it as your fuel. Fats are fats. That's right, fats are fats. This is always going to be fat. It's never going to go back to sugar. It's never going to turn into anything good unless I stop eating, and it's only good when it leaves me. But and the old idea about not making any fat cells after puberty, that's not true either. You can make as many as you need to take up the food that you eat. So remember, fat is the storage organ, and it's necessary. It's very necessary. There are a lot of good things that happen with fat, and we're gonna talk about that. But as a rule, there's a lot of inflammatory cytokines, a lot of inflammatory enzymes that come out of fat that are part of the cardiovascular complications of diabetes. So everybody understands carbohydrates. Okay, good. Next slide. Now, this is a slide that actually shows how the triglyceridone really did significantly. Triglyceridone was the Resulin that's no longer on the market, but it was an excellent drug. And you can see how the mean follow-up being follow-up is 0.9 years, but you can see how the follow-up over the years, really the incidence of diabetes was remarkably less in placebo. And the interesting thing here is in this particular study, lifestyle was more important than metformin. So the thing to remember is that lifestyle and understanding the foods that you eat and exercising and maintaining lean but mean and exercising can be very important in putting off the onset of that diabetes and at least preventing the complications of diabetes.
Marcy?
Yes?
Why is the medication off the market if it was so good?
The truth, who was anybody in my practice when we took Resulin? Did anybody here take Resulin but me? I took Resulin because I have a family history of diabetes, and I knew 10 years before the study was ever done that this was going to happen because I understood the drug. So I took it myself so that I would never get diabetes. However, it was thought to interfere with liver enzymes, and it is metabolized in the liver. And doctors were supposed to check your liver enzymes every single month if you were on Resulin. We did it. We had a whole Resulin list. Everybody that came in every month, and they got their Resulin. But when they went across the country, doctors were not doing it, so they took it off the market. That's an embarrassing thing to say, but that's why. I actually rounded up all the Resulin in the country, and I took it for 5 years after that because it was definitely the best drug. I now take Actos for the same reason. Actos is almost as good, almost as good. Avandia causes a little more of edema, and we're going to talk about that in a moment, but it's in the same category, and you get the same effectiveness with Actos. Next. This is the DREAM trial that I was going to tell you about. Now, Ramipril is a drug that's kind of like lisinopril. It's an ACE inhibitor, ACE inhibitor. There were some studies, and there still are some studies, that show that that drug actually does also decrease diabetes. This study, the DREAM study, did not show that, but it did show, once again, that that drug, rosiglitazone, did prevent diabetes. What we think the ACE inhibitors do is they seem to maintain your kidney function. Many of you are on lisinopril. I use that drug on purpose. Very much on purpose in diabetics because it does maintain endothelial function. We think that it decreases some of the oxidation and some of the enzymes inside that inflammatory process that happens inside the blood vessel wall. But the studies about it decreasing the incidence of diabetes are still up in the air, but of all the blood pressure medicines, we start with either an ACE, ACE, angiotensin converting enzyme inhibitor, or an ARB, its first cousin. That's the receptor blocker where you don't get the cough. And then there's some new drugs out, actually. The renin drugs, the renin blockers, these are brand new. Tecturna is one of those drugs. I don't think anybody's on that drug. And there was a recent study that just came out this week that demonstrated that Tecturna is a wonderful drug decreasing blood pressure. And in that study, they actually did measure the F2 isoproxane. Now, those of you who have the Z-Life and had Berkeley and Cleveland labs, you had the F2 isoproxane. It is a very important enzyme in the inflammatory process inside that red blood cell, and those drugs decrease that particular enzyme. And so we think that it's really important, particularly with cardiovascular disease. I'm going to continue to use them as blood pressure medicines. And in some of you, if you have an elevated F2 isoproxane, I will probably use a little bit of it to try to decrease that inflammatory process inside your red blood cell. But I don't use it to prevent diabetes. Next. Move that over just a little bit if you can. This is the pancreas. The pancreas is thank you, the gland we're talking about. The pancreas is located way back here. It's along your back. Has anybody had pancreatitis? It's horrific. You've had pancreatitis. It often hurts right in your back. People will complain of back pain or a boring pain in the back because the pancreas sits behind the rest of the intestine, really along the back. It has many important functions. There are tons of enzymes that are important in the digestive process, but it also has the islets of Langerhans. And in the islets of Langerhans, I don't know who Langerhans was. He was obviously famous and he had these islets named after him. I came along too late. There will never be a Zwelling anything. Maybe a Zwelling disease, talking too much. But in the islets of Langerhans, we have the alpha cells, the beta cells, the delta cells, and the gamma cells. And we're going to concentrate mostly today on the alpha cells and the beta cells. You've not heard me mention the hormone amylin. There is a drug that simulates amylin, and we'll talk about amylin in a little while. But glucagon, insulin, and amylin are three of the very important hormones that are really about the process of diabetes. Next slide. This is just a representation of the islets of Langerhans, the beta cells and the alpha cells, and of course the delta cells making somatostatin. Somatostatin is a hormone that's affiliated more with your intestine and the absorption of food. We're not going to concentrate on that hormone today. Next. The beta cell, the famous beta cell. This is the cell. This is where it's happening. This is the cell that's in your pancreas, in your islets of Langerhans. You can see that it sees glucose. The glucose transporter takes glucose into the cell, and the mitochondria is where all the action is. As a result of the glucose being the beta cell being exposed to glucose, insulin is secreted. It's just that simple. That is its job, insulin secretion, and then of course amylin secretion, specific to different beta cells. But the beta cell is where it's happening. Now, if I told you that beta cells die off, you wouldn't be a bit surprised, would you? Because all of our cells sort of kind of die off. But again, the genetics is what matters. So if your genetics is such that these beta cells die, it's a process called apoptosis. You know, in medicine, we have to have 3, 4, 10 syllables. You know how that goes? Because we have to pretend we know more than anybody else. But it just means cell death, okay? So the cells die. In addition to that, in people with diabetes, they're not as sensitive. So as much as the glucose goes in, you don't get as much insulin out. And I'm going to show you some slides about why that's important. Next slide. This is the normal person. The normal person eats a meal, and it doesn't matter. Can you see that the normal person, the top line there, hardly any change in glucose? The normal person does not get that after meal, oh, I think I'm tired, I have to go take a nap. But most diabetics will tell you, after a meal, when their sugars go up to 150, 200, 250, if they're not regulated, you get tired. I get tired. So, and it's particularly after a carbohydrate meal. But if you don't have any problems with insulin sensitivity, and if those beta cells are working, the normal person has hardly a glitch in their sugar. Hardly a glitch. And indeed, some people, I check their sugars, and at 1 hour they're at 110, at 2 hours they're 120. Nothing. Nothing. They are absolutely normal. Those beta cells are in tune. The insulin, in response to that glucose entering that beta cell, that insulin shoots out immediately. And look at that. Within 60 minutes, it's already peaking. Very important. The other, and perhaps equally or more important, although these studies are just being done, and this is the next place where Zwelling is 5 years ahead. I can't even get the lab tests done the way I want them. But glucagon goes down. Now, glucagon is a very important hormone, as you'll see. It goes to the liver. During the night, when you're not eating, have you ever wondered in the morning you get up and if you check your sugar, you still have sugar, right? Your sugar can be 110, 120, 130, fasting sugars. In fact, we used to monitor fasting sugars in order to determine diabetes. And everybody would say to me, Marcy, I didn't eat all night long. Why is my sugar 250 in the morning? Well, the glucagon is, and there are a variety of reasons, but among them, glucagon goes to the liver. It tells the liver to convert protein into sugar, to convert that stored glycogen back into simple sugars, and it goes out into the bloodstream because you must have sugar. You've all seen documentaries or pictures of someone with an insulin reaction. An insulin reaction is someone whose sugar is too low. They have too much insulin. So their sugar goes down, and what happens? They can't think, right? They become delirious. Their mental status changes. Put some sugar on their tongue, have them drink a sip of orange juice, and what happens? They wake up immediately. You've seen that, right? Well, that's because the brain has to have sugar. The brain does not function on fats. It does not function on fats. It does not function on fats. It's got to have sugar. So you've got to maintain a sugar level in order for your brain to think. And so as a result, the body tells the liver, let's keep the sugar up. And it does that through the hormone glucagon. Similarly, you can see how quickly sugar gets absorbed into the system. All it has to do is touch the tongue or the mucous membranes and zap. It's in your bloodstream and in the brain, just that fast. And you've seen that. You've all seen that, right? You give them just a sugar pill and poof, they wake up immediately. Of course, if you don't keep feeding that person, their mental status will decline again. But that tells you just how quickly it doesn't require any enzyme system. Glucose passes through just lickety-split into the brain. And insulin does not cross the blood-brain barrier, so it doesn't even need the, it doesn't need the insulin to get there. Okay? Next slide. The amylin that we were talking about, that's a very important hormone too. We don't hear a lot about it, but it inhibits the secretion of glucagon. So when you eat, the amylin that is also shot out from that beta cell tells the liver, okie dokie, we got plenty of food, you can go to bed now, you can sleep. We don't need any more sugar. The amylin is one of those hormones that helps stabilizes that sugar. It slows the emptying of the stomach and it sends a signal to the brain to be full. Does it make sense that amylin might also be dysfunctional at diabetes? That's exactly what happens. And there's actually drugs that stimulate amylin, but they're injectable drugs, which is why you don't see them a lot. Next slide. Insulin. This is what insulin does. Insulin stimulates our skeletal muscle to take up glucose and converts it into glycogen. The skeletal muscle takes up the sugar, it uses what it needs, it stores what it doesn't. Now, in spite of what everybody has been told, you've seen runners, they all glucose load, right? They all carbo load. But in truth, you can only carbo load up to about 1,800 calories total. Even in a person who is, an avid runner and who has practiced it a lot, you can't increase your glycogen stores that much. It does help, but only about 1,800 calories worth. It stimulates the muscle also to take up amino acids and convert them into proteins. It acts on the liver to take up glucose and convert it into glycogen. Can you see what insulin is doing now? It's bringing the sugar into the system and it's acting to keep things stored. It's one of those plus hormones. So with insulin, with lots of insulin, you're going to store a lot of stuff. And that's an important fact to kind of remember. It acts on the liver to inhibit glycogenolysis, or the breakdown of glycogen, and it inhibits gluconeogenesis, or the conversion of fats into protein into glucose. It acts on adipose cells, those are fat cells, to take up glucose and stimulates fat synthesis, and it also reduces your appetite. So it's one of those plus hormones. It acts to build things. It's a builder. Next slide. Glucagon. That stuff that's coming from the alpha cell. It goes to the liver and it converts the glycogen into glucose. It acts on the liver to convert protein into intermediate metabolites that will also become glucose. It stimulates low glucose. It is stimulated when there are low glucose levels in the blood. It is inhibited by high levels of glucose or after you've eaten, and it's also inhibited by amylin. So glucagon is absolutely the antithesis of insulin. So the normal person, next slide. The normal person eats and they have an immediate insulin response. Look at that insulin. Can you see the top line, which is the pink, a fasting sugar of 79 to 89? That's the normal person. Look at that insulin. Beautiful response. Eat that food. Poof! Insulin is popped out of that beta cell doing all those positive things. On the other hand, look at this person with a fasting sugar of 150. Hardly any response. Even a fasting sugar of 100 to 114, look at the diluted response. That beta cell is in slow gear. It's tired. It's not giving you the oomph. It is not in prime function. That's called beta cell dysfunction. And that's one of the first things that occurs with diabetes. You don't get that oomph of insulin. So that when you eat, that food doesn't get into the cell and the sugar dilly-dallies around in your blood for far too long, making us tired and doing a whole bunch of other not such good things. Next slide. Now, this is the last slide that we saw superimposed with the not so good person. This is the type 2 diabetic. So as you can see, compared to the normal diabetic, sugar levels go up appreciably after eating. Compared to the normal person, the diabetic has a very, very, very weak response of insulin. Can you see that? And look what happens to the glucagon. It goes up. It is my feeling that this is probably one of the primary defects in diabetes, and that we can probably diagnose it a lot earlier if we could measure glucagon levels. I have been begging labs to do glucagon levels for you at pre-diabetes because I really feel that that is a very important predictor of diabetes. When that glucagon level goes up in response to eating, your liver is actually making things worse instead of helping you. You've already demonstrated that you got an oops in that pancreas. And I promise you that that will be a new, and this obviously could be another place of treatment, right? Make sense? So it's not just the alpha cell or the beta cell. It's not just insulin and amylin. The glucagon is very instrumental. So here you are, you're a diabetic, you're trying hard, and your own body's just acting against you. That glucagon, which should be going down, is going up. What the heck is that about? That's the genetic predisposition. That's the islets of Langerhans and those hormonal cells, the alpha and beta cells in dysfunction. That's genetic. That's way before anybody's gained weight. But you can see that indeed the dysfunction starts very, very early, and it's a cellular dysfunction. Next slide. This is again another slide showing you the same thing. This is the non-suppressed glucagon and the suppressed glucagon. And you can see that as you move out in time, the non-suppressed glucagon goes way up. You can suppress glucagon, and we're going to talk about how we're going to do that in a moment, because there are some drugs that will help with that. You can actually suppress the glucagon response post-eating, and that is an important part of the diabetes treatment. Next. Beta cell mass. This is another really important philosophy and now fact, actually. The people on the left are lean. The people on the right are obese. You can see that the lean person, the lean normal person, has a beta cell volume that is much higher than the lean diabetic. The skinny diabetic loses beta cells. Remember the apoptosis, I mentioned cell death? They die. They die in diabetics. Skinny diabetics lose it just like fat diabetics. Fat diabetics lose even more. But if you don't have the cells to make the insulin, you can't get much of an insulin response. So two things happen. Number one, the insulin doesn't pop out. And number two, you don't have enough cells to actually maintain an adequate insulin response. So those two things, the cell death and the cell, we'll call it slowness. It's a retarded cell. So that is the diabetic, but you can see it is in the lean person and in the obese, but it's magnified in the obese person. Next slide. These were autopsy studies, actually. This is, this gets back to, my hissing and moaning about the current treatment of diabetes. I fight with your drug companies all the time, with your insurance companies, about getting you your drugs, because your drug companies want me to give you glyburide first. Glyburide is a drug, it's a sulfonylurea. It stimulates the body to make more insulin. It stimulates the beta cell. That's not the problem. You gotta keep the beta cells functioning normally. Having them make more insulin as an isolated response does not solve the problem, as is indicated in this slide. So you can see over time, the failure rate of people on glyburide is, I'm telling you, it's 100%. Everybody fails. Everybody fails. I don't use it at all. Your drug companies, your insurance companies, that's the first line drug. It's cheap. It's easy. What the heck? You know that I start you usually on Janumet, and we're going to talk about the Januvia part of Janumet in a minute, and Actose, and this is why. Even as single dose response, you get failure much over time, many years out, but what you'll see as we go on that using 2 drugs, one of them being the new GLP-1 drugs, the incretins, you actually can stimulate beta cell mass. It acts on stem cells and you actually get that mass back. There is the miracle drug. It's not covered by anybody. God forbid we should do the right thing. Go ahead. These are the incretins. How many of you are on Januvia or Janumet? Januvia is the new miracle drug. I take it. These drugs are analogs of the GLP-1. GLP-1 is a hormone that is made in the intestine. Everybody makes it. Diabetics don't make enough. Probably, once again, part of the genetic issue. This drug is so important that it actually, you can see that it increases insulin production and it decreases glucagon production. And as you'll see in a chart later, it even acts on the bones to maintain bony mass. It looks like it is like the panacea. It's like the guy that's going to extend your prime, and it really does. Next. This is how it works. It goes to the brain. It tells you, hello, you just ate, you're full. Wouldn't that be nice? That would be wonderful. It actually helps give you cardiac protection. You know, diabetics, long before you ever have a heart attack, when we look at that heart and we're looking at the elasticity of the heart muscle, we see that it has what we call diastolic dysfunction. It's a little stiff in diabetics, probably because of some of the issues with the vascular supply. We'll talk about that in a moment. So far before you ever have a heart attack, you are already feeling poopy because that heart is not functioning appropriately. These drugs will help with that cardiac protection. It decreases gastric emptying. It decreases glucagon secretion so that after you eat, that glucagon level goes down. You're not acting against yourself. It increases the biosynthesis of insulin, and it brings beta cell proliferation. It makes them. We think it's done through stem cells, but actually that beta cell mass will improve. So even if your diabetes is found relatively late, you can improve it. There's hope for everybody, see? It decreases the beta cell death. It decreases glucose production in the liver, probably because it decreases glucagon secretion. It increases the glucose disposal, meaning that it helps the muscles take up the glucose. It increases lipogenesis, and look at that. It increases osteoblastic activity. Those are the cells that help make good bone. Could we ask for a better drug? Is this like manna from heaven? This is manna from heaven. Now there are two types of drugs in this category. One of them we've used is called Byetta. It is an analog of this hormone, but the hormone is a protein. You can't take it by mouth. If you did, it would be digested in your stomach. So you have to take it as an injectable, which is why many people just hate it. It causes a little bit of nausea. Outside of that, it works beautifully. The drug that's taken by mouth is a drug called Januvia. And there are a number of them. Januvia was the first one to come out. I use Januvia, and what Januvia does... You okay? Okay. You want water?
No, I'm good.
Okay. What Januvia does is it acts on the enzyme that gets rid of the GLP-1. So you eat, GLP-1 comes out of the cell, and then the enzyme immediately starts to metabolize it. It interferes with that enzyme, so that even though you make less GLP-1, it hangs around longer. Now, the good news is that the analog, the injectable, as you'll see, actually causes weight loss in diabetics, You haven't heard that one in a while. Januvia does not cause the same weight loss, but the injectable, for those people who are willing to take it, it causes weight loss. It acts to absolutely prolong those beta cells. The better drug is definitely the injectable. There are new drugs out now that are once a day instead of twice a day, and I'm sure there'll be newer drugs because this is the newest and the best. So many of you are on Janumet, Januvia, and metformin because both drugs together actually give you incredible improvement. Some of you are on Januvia, metformin, and Actos, because it gives you the maximum.
What's GIP?
GIP is another hormone. It does not have we have not found it to be influential in this. Go ahead and change the slide. So this gets back to that major theme that I was working on. As you can see, GLP-1 treated animals have increased beta cell mass. It actually takes those cells and it gives you a normal looking, beta cell mass. That is incredible. We have never seen a drug do that. For all intents and purposes, we're reversing the disease. That's an incredible thing to say. And imagine a disease that causes as much havoc as it does, and we have a reversible drug. Next. Weight gain and beta cell function, just what you didn't want to see. I know I keep talking about weight, but it really is important. Beta cell function does go down in the overweight. There's just no question about it. Glycemic control, as you can see, gets out of control, and your beta cell function, it just goes down. There are a number of reasons for that, but for the most part, when you're obese, you're asking those beta cells to just do too much. Lean and mean, it just has to be the answer. Now, it's not easy. I mean, I'm a fat girl. You know that. I am a fat girl. Been a fat girl all my life. I'm not so fat now, but I don't eat. I eat well. I eat protein. I have my egg beaters for breakfast, right, Joni? Every morning, my egg beaters. And I pick at food. I eat smaller portions. I exercise on my Stairmaster. I'm saving my own life. You know, my mother had a stroke. I will not have a stroke. And no one in my practice will have a stroke. You will not have a stroke. And if you need help in weight loss or in any of that kind of stuff, I'll talk to you every day if I need to. Because I'm telling you, it changes your life. It makes you feel better about yourself. You've got more energy. And look what you can do. You can change your life. You can extend your prime. You can make every day a better day, right? That's what we sell here. Go ahead, Joni. So this is another slide. I know I'm just harping on this, but you've never heard this before because this is not what the media talks about. This shows you that indeed the vildelactobin is the drug that we're talking about. That's Januvia and metformin, and you can see how you can improve beta cell function, and that's Janimet that I put you on. Next slide. This again shows you the GLP-1 and how it helps with beta cell mass. It decreases cell death and cell shrinkage, and it leads to bigger and plumper beta cells that work better, and it also recruits new cells. New cells! I mean, this is like stem cells on steroids. This is cool. This is really cool. Next slide. So let's not forget that, and I don't want to overwork this, but indeed, it's very important to remember that a lot of this is genetic. So we're not about blaming ourselves, okay? I'm a short person, been short all my life. I have to wear high heels, and if I had high hair, if that was in style, I'd wear high hair. So we are what we are. It's okay. But it's so good to know that no matter what we are, we can make it better. This is not something that most people think about. You know, it's like, oh, well, I've got diabetes. No, you don't just have diabetes. You have something that you can take care of, and you can change your life. You can extend your prime. I mean, imagine a stroke. Have you ever seen a person with a stroke? Anybody here seen a person with a stroke? I mean, is it not the most disgusting thing in the world? I mean, is this not a reason to work hard on extending your prime? I got to tell you, I lived with my mother for 6 years. It is an inhuman thing to let somebody suffer through. It is just, and it's unconscionable to let that happen in today's medicine. It's unconscionable. Next slide. I love this picture. Isn't this great? So the orange is fat. So this is really important because the TZDs, those are those triglycerides that I put you on. Triglycerides actually work on fat topography. Where is your fat? It actually does matter. So subcutaneous fat, you know, the baby fat that we talk about, the fat that my mother told me I never lose. She used to tell me that I laid so quietly in bed and never moved that's why I always had too much baby fat. That was my mother. What can I tell you? Don't you just love it? Don't you love it? But anyway, trust me, it wasn't all baby fat. But in any event, what we see here is with the triglycerides, we're actually able to take intramuscular fat, hepatic is liver, and intra-abdominal fat, and actually with the TZD, we make it subcutaneous fat. And that is actually different fat cells. We don't all have this, they're not all the same fat cells. They actually have different function. And it reduces the macrophage infiltration. Macrophages are white blood cells. And in future lectures, we're going to talk more about those white blood cells because that's the inflammation that we're trying to prevent inside the vasculature, inside our blood vessel wall. Inflammation is a bad thing. It is a bad thing. It is the cause of heart disease. And so we want to shut off that inflammation. We want to cool down those arteries. And we can do that by moving all of this intra-abdominal and intramuscular fat, which actually increases inflammation, to more subcutaneous fat. And I suppose we'll get rid of that with liposuction, right? Go right ahead. So, in future lectures, and this is kind of just to tempt you, there are so many fascinating things that are happening now, that what we're learning about what does change our food intake? What happens when we eat? What hormones? What else is there out there? Every single drug that seems to come out to help us lose weight, they take it off the market. I think the FDA is like, what can I say? But in any event, there are external factors that increase, that regulate our food intake. Obviously, some of us are emotional eaters. Emotional eaters, everybody? Yes, of course. Environmental cues. I mean, how many times can you walk by a chocolate chip cookie and not eat it? The answer is none. Lifestyle behaviors and food characteristics. Those things we can change a little bit. But some of it, it's where you work, what you do. We're not going to change that. We're not going to change who you are. So we have to work with those things, but we can modify them. But in spite of all that, there are tons of things that are happening. Of course, when we intake food, it goes into the GI tract. It goes, and this is the fat cells, and these are the adrenal glands. And in response to eating, look at what happens. There are peripheral signals, glucose, the GLP-1 that I was talking about. That's a special polypeptide. CCK is a hormone that acts with the gallbladder. Insulin, amylin, ghrelin, leptin. It doesn't even mention adiponectin and cortisol. All those things influence not just our food intake, but what happens to the food. And in future lectures, we're going to talk about all that stuff. But indeed, it's so complex and complicated. Today, though, I want you to remember that just diabetes itself, just with decreasing the amount of food on your plate, decreasing the carbohydrates on your plate, you can change your life. You can extend your prime. Next. And in future lectures, we're going to talk about this postprandial glucose. We talked a little bit about that. that isoproxane, that F2 isoproxane. That F2 isoproxane is an oxidative stress hormone. Those are the hormones that drive heart disease. Those are the hormones that influence that intravasculature inflammation that causes that heart attack down the line. And so it does matter what your sugar is. It does matter after you eat. Again, I hate to belabor the point, but do you remember the days when everybody just checked their fasting sugar? Do you remember that? I mean, and diabetes is not a disease of fasting, is it? It's a disease of eating. It's what happens when you eat. We had our head somewhere when we were doing fasting sugars. That's craziness. That's still done today in some offices, but I don't care what your fasting sugar is. I want to know what your postprandial is, and what should it be? Less than 140, ultimately. So when you're checking your sugars, if you're checking, check your sugar. I can lend you a machine if you want to over the weekend. If you're interested and you don't want to buy one, that's fine. Most of them, the insurance companies will let you buy one. I don't like to put you through, heck and back. I don't want you to become a prisoner of your disease. But it is important to see what happens after you eat. And that is really where the money is. We need to keep that postprandial, prandial being after eating, that postprandial glucose down. And you can see now that if you've got a beta cell that's up and running, raring to go, a Corvette for a beta cell, you can actually maintain a normal postprandial glucose. You can decrease oxidative stress and therefore decrease intimal wall thickness. If you're in the Z life, you get your intimal wall checked. Those are the things that we already know will make you better right off the bat. How soon does it work? Immediately. Immediately. Did you see those graphs? They didn't wait for 3 years. They immediately started to change. Immediately. Next slide. So, in the management of diabetes, hemoglobin A1C, that's the glycosylated hemoglobin that I was talking about. The standards of care are less than 7. In this office, it's 6 or less. That is really my goal. Preprandial plasma glucose, I don't really care, although they say 90 to 130. Postprandial less than 180, it should be less than 140. Blood pressure less than 130/80, that's also malarkey. You need it to be 110 or less, particularly if you're a diabetic. The LDL sugar, the LDL cholesterol needs to be less than 100, and there are some studies that show that it should be as little as 60. The triglycerides, 150 is way too high, and we used to also check triglycerides in a fasting state. Again, ridiculous. They need to be checked post-eating because they go up after eating. HDL cholesterol greater than 40, and in women greater than 50. Antiplatelet therapy as needed, that's Plavix and the like, and we use that for some people who've had a stroke, God forbid, and obviously you should stop smoking. The HDL cholesterol will also be a subject of one of our next lectures. There's tons of studies on this. We know that there are some people with very good HDL or good cholesterols that are still having disease. But there's some really interesting stuff, and I'll tell you about a new study. It was in your newsletter if you read your newsletter. But this is fascinating. You know, we talk about the statins when we talk about heart disease, right? This study was talking about HDL efflux, the ability of HDL to grab that cholesterol out of the inflammatory cell, get it out of there, take it back to the liver, get it into the gut and out of the body, get that cholesterol out. That's what HDL does. It's the rescuer. Does the amount of HDL, is that what's important, or does its operational coefficient? Like how good does it operate? Is it a guy who's just sitting around doing nothing, or is it really in good operational mode? What they showed, interestingly enough, was that the drug Actose, that's right, that glitazone that I was talking about, and this is one of the reasons why you're on Actose as well, is that the Actose actually improves HDL efflux of cholesterol, not the statins. Not the statins. Now the statins are antioxidants, they're anti-inflammatories, and they are important. But here's where Actose comes into play. The triglyzones seem to actually make that HDL a better molecule. Pretty cool, huh? That just came out just last week.